Welcome, brothers and sisters, to your wellspring of knowledge. Remember that knowledge never be toxic to brain, but public
Medicine
serving
and
and
health.
saving oriented.
You are together with Joseph Ndaishimiye. Now we are going to present on the nausea and vomiting part 2, which is postoperative nausea and vomiting. I think you have enjoyed the first presentation on this topic. Most welcome. Friends, in this topic, we are going to cover three things. Now we are going to review the introduction to postoperative nausea and vomiting. And now we're going to see the risk factors to postoperative nausea and vomiting. Who is at the risk of developing or experiencing nausea and vomiting after surgery? Now, after we end up with pharmacological and conservative concerns for postoperative nausea and vomiting. Friends, remember in the first presentation, we have been talking on nausea, vomiting. The same story now. The difference is that we are going to be mostly concentrated on the nausea and vomiting that arise after surgery. Now, what's PONV? It refers to nausea, retching movement, or vomiting that a patient can experience during the first 24 hours after surgery. To mean that before or after 24 hours, you cannot relate it to the operation. Now, postoperative nausea and vomiting is one among the commonest complications that lies after surgical procedures. Friends, do you know why it's most important for us to control the postoperative nausea and vomiting? Yes, we have to do so because once it's not controlled, it can lead to postoperative morbidity like pulmonary aspiration of stomach contents, fluid and electrolyte disturbances. I think you know this can aggravate the situation and also can also lead to decreased patient satisfaction and even death. Friends, we have talked much about nausea and vomiting in the previous presentation. Please, before proceeding with the second presentation of nausea and vomiting, what's better for you is to first review the first presentation so that you can understand this part 2 at a good extent. But in a simple way, as we have said, nausea, it's noxious and a present recognition of desire to vomit or to throw up. Now, the vomiting or emesis, it's the completion of that desire of throwing up the GRT contents. Now, we are going to review three main things which are medullary vomiting center, chemoreceptor trigger zone, and cerebral cortex. These are the three main centers. We have to talk on it a little bit so to understand well what's behind postoperative nausea and vomiting. Friends, remember in the first presentation, we have seen that to have nausea and vomiting, there must be a methodogenic stimuli. There must be a methodogenic stimuli to mean that the story is the same. In the lateral ventricle, we have what we call lateral reticular formation, which lies in medulla oblongata closer to the floor of fourth ventricles, near the obex. I have talked in the previous presentation that obex, it's the points where medulla oblongata, where spinal cords and the medulla oblongata opens to one another to allow communication in between. And we have said that for this lenticular formation, which lies in a medulla closer to the floor of fourth ventricle, there is integrative vomiting center, which we call medullary vomiting center. Now, what about this? This center receives the afferent signals from chemoreceptor trigazone, vestibular apparatus, cerebellum, cerebral cortex, uh, brainstem, yes, and nucleus tractus solitarius. All those regions mediate vomiting reflex to medullary vomiting center. Friends, why these structures are they important? They are rich in dopamine, mescaline, serotonin, histamine, and opioid receptors. And remember, those receptors are the one to mediate the vomiting reflex. Therefore, it's most important to be well equipped with this main center, which is medullary vomiting center. Now, second, we have chemoreceptor trigger zone. Chemoreceptor trigger zone, as you have said, before going to it, you have to remember that from the integrative vomiting center, the efferent signals are transmitted via cranial nerves, trigeminal nerve, which is 5 cranial nerve, and 7th cranial nerve, which is facial nerve. We have ninth cranial nerve, which is the glossopharyngeal, and 10th, which is hypoglossal nerve. All those nerves with spinal nerves to diaphragm and abdominal muscles are important to cause a mechanical act of vomiting. On the point of chemoreceptor trigger zone, you have to remember that chemoreceptor trigger zone, CTZ, is near the area postrema. I have said in the first presentation that there's two words, area postrema and chemoreceptor trigger zone, are most used interchangeably. Yes, CTZ is near area postrema on the floor of fourth ventricle, near the obex, outside the blood-brain barrier, to be elicited by substances in the systemic circulation and as well as those in CSF or cerebral spinal fluid. Friends, remember, cerebral cortex is once stimulated by smell or physiological stresses, such as surgery or surgical experience. Motion can also stimulate the vestibular apparatus that we have seen, which may also stimulate the chemoreceptor trigger zone via cerebellum. The neurovegetative system is sensitive principally to gastrointestinal stimulation. Now, friends, remember, we have seen that to have vomiting reflex, all those three regions, including NTCS, nucleus tractus solitarius, must be stimulated. But remember, chemoreceptor trigger zones and the vomiting, remember, chemoreceptor trigger zone lies outside the brain barrier, to mean that can be elicited by systemic circulation of emetogenic substances. Second, you have to remember that once you have gastrointestinal pathologies, it's somehow particular, because once you block the receptors on chemoreceptor trigger zone and block those on and uh, and block on those receptors, you can have vomiting, especially from GIT, because there is another particular way of stimulating integrative vomiting center without passing to chemoreceptor triggers, which is a type of nuclear that is found in medulla oblongata, which is nucleus tractus solitarius. Friends, to sum up on this, remember, blocking the impulses from chemoreceptor triggers does not prevent vomiting due to irritative stimuli on GIT, for example, gastroenteritis, intestinal obstruction, vervus, all those arising from GIT, because there is a direct action of to nucleus tractus solitarius. Yeah, to sum up on this, the physiology of postoperative nausea and vomiting, uh, you have to remember that to have postoperative nausea vomiting, many factors must play a role. Now, let us go on with the risk factors who are at the higher risk of developing postoperative nausea and vomiting. These risk factors are classified into four main categories. We have patient related, we have anesthesia related, we have surgery related, and the postoperative factors. On the point of patient, uh, the female gender is mostly ex at the high is mostly exposed to vomiting center postoperatively, especially those with menstruating or pregnant, because of higher concentration of sex hormones such as uh, progesterone or estrogens. The second point on the patient, friends, you have to remember that in the children uh, aged more than 3 years are also exposed on this problem of nausea and vomiting postoperative. The same story to non-smoking patients and those patients with history of motion sickness or postoperative nausea and vomiting in a previous surgery. And another point on the patient, anxiety patient also expose the patient to nausea and vomiting. Yeah. Only the point of anesthesia, friends, you have to remember that every patient undergone more than 60 minutes under surgery with general anesthesia is at higher risk of developing postoperative nausea and vomiting. The second point, we have drugs, especially opioids. On the point of opioids, you have to remember that perioperative use of opioid increase the risk of postoperative nausea and vomiting in dose-dependent manner. How? By decreasing uh, the muscle and the peristaltic activity of GIT, thereby delaying gastric emptying, inducing distension, and triggering the vomiting reflex. The second of this, there is what we call volatile agents, especially nitrous oxide. Nitrous oxide, this also may increase the postoperative nausea and vomiting together with all volatile agents where they decrease the serum level of anandamide, which is the endogenous cannabinoid neurotransmitter that acts on cannabinoid receptor 1 receptor. So you have to be cautious once you use those volatile anesthetics, especially much concern when you are using nitrous oxide. On the case of surgery, we have strabismus or stent surgery, which those surgery in ophthalmology also elicit uh, vomiting reflex. Those neurological surgery, we have ear surgery, laparoscopy, tonsillectomy, breast surgery, ocupex, which the operation to bring an undistended testicles into scrotum. All those with gynecological surgeries elicit vomiting uh, postoperatively. The postoperative factors, the use of much opioids postoperatively, or hypotension, also this with the dehydration can elicit vomiting reflex and vomiting. Yeah, friends, this is very important in the obstetrics. Uh, Especially in a pregnant woman, most time, especially in the first trimester, they experience severe form of nausea and vomiting, which is hyperemesis gravidarum. In their management, we use many things, but please, you have to install the use of antiemetic drugs. And the most severe form, this hyperemesis gravidarum can lead to dehydration, uh, hyponatremia, hypokalemia, and the other metabolic disturbances such as hypochloremic acidosis, ketonuria, and loss of body weight. And you have to remember that the first line in the treatment is are we consider IV fluid electrolyte replacement, but please remember the antiemetic therapy for better treatment of this population. Yeah, in the management, you have to know and to be well equipped with the most common drugs we use in obstetrics to prevent or manage hyperemesis gravidarum. We have vitamin B6, the antihistamines blockers, histamine 1 blockers, phenothiazides, ginger root extract. All those are safe for the use in the pregnancy. But remember, the risk is not exhaustive. We have also uh, methotrexate, dopedo, and ondansetron. All those can also act because they are effective too. Remember, the pregnant woman lasts long period of time in labor. Once you use anesthesia and analgesia in labor, you have to know that most time the hypertension is somehow linked to nausea and vomiting is directly linked to hypotension induced by uh, the central neural blockade or cerebral hypoperfusion. Yeah, now how can we treat postoperative nausea and vomiting? Um, we have many choices, but we conservatively treat this problem or prevent it by omitting or reducing the use of some medications. For example, first thing to do, you have to consider the choice of anesthetic technique in the prevention of postoperative nausea and vomiting. First one, you have to omit the use of nitrous oxide. Why? Friends, you have to remember that nitrous oxide was the most pronounced methodogenic inhalational anesthetic during general anesthesia. Therefore, to make another choice is the best choice. Second, please don't use higher doses of anticholinesterase, for example, neostigmine, because they increase salivation, lower esophageal and gastric tone loss. Gastric acid output also increases, and the GIT motility also decreases. Thus, nausea and vomiting can occur during reversing of neuromuscular blocking agents. Yeah, for example, vecuronium, panclonium, all those during reversing them, you have to be cautious on the dose of uh, anticholinesterase. Third point is use of propofol. Please, you have for better if your patient is dynamically stable, use propofol. It's the best uh, IV anesthetics. It's antiemetic, antiemetic IV anesthetics. How does it work? Propofol appears to process the intrinsic antiemetic activity, possibly by the antagonism to dopamine 2 receptors. Another point, please, you have to avoid the ether. Ether. Ether is one of the most emethogenic of all inhalational anesthetic agents. Third, last, you have to prefer the use of regional blockade instead of use of general anesthesia. It's useful technique in the prevention of postoperative nausea and vomiting because it requires few drugs compared to general anesthesia. For example, we can use few opioids in the spinal anesthesia compared to general anesthesia. Now we go on with the pharmacological management of postoperative nausea and vomiting. Friends, it is so fascinating to know that the drugs referred to antiemetics, some have more anti-nausea, but less anti-vomiting effects. But others have less anti-nausea, but more anti-vomiting effects. Let us pass through this. First class in the management of postoperative nausea and vomiting is the use of anticholinergic antimuscarinic drugs. Friends, the anticholinergic drugs can, they are able to cross blood-brain barrier to mean that they will act directly on the vomiting center and they have and then produce antiemetic effects. And you have to remember that both atropine and hydroxyscopolamine are still used to treat nausea and vomiting. But you have to remember that scopolamine are more potent and effective than atropine. And the scopolamine somehow good compared to atropine in this way. Scopolamine is more sedative compared to atropine, to mean that you don't need much inhalational gases for the patient to sleep because scopolamine has higher percentage of reducing mark of inhalational anesthetic. Please, what is mark? Mark is the minimum alveolar concentration of the anesthetic agents. So, opioid anticholinergic drugs decrease the amount of gas we need for the patient to sleep and not respond to surgical stimuli. For this, they can be effective against motion sickness, labyrinthian disease, vestibular disorders, that arise postoperatively. Yeah, yeah. But you have to remember that atropine are absolutely contraindicated in a closed angle glaucoma because it can exacerbate the increased intraocular pressure. On the second point, we have the antihistamines. Friends, this group of drugs is similar to the above in that they act on the vomiting center, antagonizing histamine 1 receptor. Remember, in the first presentation, we have said that on the medullary vomiting center, we have many receptors, but among them we have histamine 1 receptors. So this makes this class to be best selected in the treatment of nausea and vomiting. Uh, they are effective also in the treatment of motion sickness, management of labyrinthian disease, and to counteract the emetic effects of opioids. For example, promethazine and cyclizine. Promethazine, remember, it's not, it's antihistamine drug, but which falls in the class of phenothiazides because it blocks the dopamine 2 receptor. Uh, you have to know that the sedative effect of antihistamines are additive with that produced by anesthetic agents. Hence, the care must be taken with their use to prevent uh, delayed recovery due to use of much sedative uh, medications. So, and you have to know that promethazine is said to have a slight analgesic effect. The third class of medication used to control and prevent the postoperative nausea and vomiting, you have dopamine antagonist. This class, in this class, you have five subclasses: phenothiazides, butyrophenons, we have metoclopramide, domperidone, and serotonin receptor antagonist or 5-hydroxyglutamaine 3 receptor antagonists. Yeah, in dopamine, there is a wide range of drugs that antagonize dopamine 2 receptors at the either chemoreceptor trigazone, or also integrative vomiting center in medulla oblongata, thereby producing antiemetic properties and effect. Among those you have said, we have subclasses which are five in number. In the first class, friends, you have to keep in mind that in the first class, which is phenothiazide, you have to keep in mind that prochlorpromazine and the promethazine are the only phenothiazide that antagonize both histamine 1 and dopamine 2 receptor, as I have said. Second, we have butyrophenons. This group of drugs was originally developed to treat major psychosis, for example, schizophrenia. It includes haloperidol and hydroperidol. A very nice drug, mostly used in a clinical setting, which is metoclopramide. Metoclopramide, in addition to having the effect on the chemoreceptor trigazone, metoclopramide, it has prokinetic effect where it promotes gastric emptying and segmentation, the peristaltic movement of GIT, and then it increases the barrier pressure on the lower sphincter of esophagus. So it's a very best medication, but which is contraindicated in intestinal obstruction. We don't use them to control uh, nausea and vomiting. We have also domperidone. This is similar to metoclopramide, but does not cross blood-brain barrier, therefore not associated with sedation or extrapyramidal side effects. It's not effective against motion sickness because it does not penetrate in the brain, in the central nervous system. And you have to know, and you have to know this that droperidol can also cause cardiac arrhythmia once used in large doses. Uh, the fifth subgroup of dopamine antagonist, we have 5-hydroxytryptamine through receptor antagonist, which is also known as serotonin antagonist. In this class, friends, you have to know that those medications are somehow most expensive group of antiemetics, and their main action is to antagonize serotonin. Serotonin release especially in the nerve endings of GIT, but also in the chemoreceptor triggers on CTZ, and it may also have the peripheral effect. The peripheral effect, for example, we have in this class you have ondansetron. We have also other medications which we are going to see. Friends, this is the table that summarizes the drug class and doses for producing therapeutic effect. First drug here, it's atropine. Atropine, it's anticholinergic. Yeah, it's anticholinergic to mean that it's better prevent to prevent salivation and then nausea, vomiting. We use mostly between 0.3 to 0.6 AM or IV, but for better, please give it to patient between 30 to 60 minutes before operation. Uh, Larger IV doses, remember that the larger IV doses of atropine up to 2 milligrams may be required to completely block cardiac vagal nerves in treating severe bradycardia. Second medication, we have scopolamine or hyoscine. This is also anticholinergic. We give between 0.2 to 0.4 milligrams subcutaneous or IM or 1 milligrams transdermal patch. Third medication, you have promethazine. You have seen that it's both antihistamine and the dopamine 2 antagonists. We give between 12.5 to 50 milligram orally or IM or even IV, no problem, for to have the desired effect. We have the dexamethasone. Dexamethasone, you know, it's a corticosteroid with the antihistamine release, anti-irritation. It has also anti-vomiting effect. It has also some analgesia. We give between 6 to 10 milligram IV, but if preferably in combination in cancerous patients, those patients with cancer pain. The dexamethasone has shown to be antiemetic in dose of 10 milligram. You have to remember 10 milligram in the adult, as it appears to be of the most importance in the combination of uh, serotonin antagonist, for example, ondansetron, to produce additive or synergistic effect. We have prochlorperazine dopamine 2 antagonist, which has it's dopamine 2 antagonist, but remember it holds also antihistamine effect. We give on 12.5 milligram orally or IM. We have also droperidol dopamine 2 antagonist 0.5 or to 1.25 milligram IV. Metoclopramide, which is dopamine antagonist, we give 10 milligram IM or IV, yeah, which is between 0.1 to 0.2 milligram per kg. On the Cetlon, which it is a serotonin antagonist, we give between 4 to 8 milligram orally, IM or intravenously to have a therapeutic effect. We have also granisetron. It's the friends of androsetron, but we give 1 milligram IV for the patient to have effect. Friends, we are now coming to the end. We have passed through many medications, but now which drug can we use among these in the table? Friends, before using any drug to prevent postoperative nausea and vomiting, you have to know one thing. Please find out what's available, then consider what to use, when to use it, and how to use it. Because once you are well equipped on those questions, you are able to give the the medication to correct patient, and you will be aware of having the knowledge in management of any complication that can arise from the use of that medication. Thank you, friends, for being with me throughout this presentation. Please don't forget to subscribe on the channel. This is your channel where you can find all the knowledge and